Hi, my name's Dr. Helen Fulcher. I'm a GP and I work for the Goodfellow Unit. Today I'm talking to Professor Bruce Arroll about improving the physical health of those with chronic mental health illness. Hi Bruce, how are you?
Hi Helen.
Bruce, it is clear that chronic mental health patients have higher levels of physical health issues. Can you tell us more about the scope of this problem?
Well, people with chronic mental health issues, who we call service users, have really more of everything, basically. They have 2 to 3 times the rate of premature death. They have more cardiovascular disease, more respiratory disease, more diabetes, more oral health illnesses, so that they have the whole thing, more cancers, so they have more of everything. And this is due to a number of reasons. Basically, sometimes the medication doesn't help, so particularly if they're on antipsychotic medication, so that doesn't help. And there are lifestyle issues such as smoking, inactivity, diet, and economic issues. And then there's some health system issues as well.
How does the structure of the health system impact on these patients?
Well, one of the issues is the separation of mental health services from primary healthcare services. So for many service users, their mental health is dealt with a mental health team, and their primary care is done at primary care level. And sometimes those systems aren't that well connected. There's the issue of stigma, which can be an issue in both ends. And the other issue is one of the solutions to that is to have what's called reverse shared care, and that's where there's a primary care clinician who will go and work in a mental health team to deal with the physical health issues for service users. That's unusual in New Zealand. The better system, from my point of view, is actually to have the primary care done in primary health care centres, because we have the systems for follow-up and managing, and it's our core business, basically.
Bruce, you touched on medication. What impact does taking psychiatric medication have on physical health?
Well, there can be situations of sedation, memory, and apathy. There can be specific side effects, like with clozapine. There can be constipation, hypersecretion, incontinence issues, and metabolic issues such as weight gain, type 2 diabetes, dyslipidemia, which all contribute to cardiovascular disease.
Bruce, you mentioned medications. What can we do about reducing the effect of prescription medicine on these people's health?
Well, there's the issue of being aware that the medications may cause problems, and then there's the issue of appropriateness and dosing. So the primary care clinician should be in communication with the secondary care prescriber, if that's how the prescribing's done, to get the lowest dose that will actually control symptoms. So we need to look at well-being focused prescribing, communicating well with patients, and monitoring side effects are things that need to be done in primary care.
What else can we do in primary care to mitigate some of the health issues we see in these patients?
Well, I think we have to empower our patients to look after their primary health care, as well as advocating for them. So that advocating may be meaning communicating with the secondary care teams about dosing and that sort of stuff. And we have to watch out for a thing called diagnostic overshadowing. So that's where everyone considers the symptoms to be related to the mental health, where in fact they're related to the physical health. And then there's the issue of screening people. So we should be treating people as we would with somebody else of their age and gender.
So primary prevention can be hugely beneficial for these people. What should we be screening for?
Well, we need to be screening for cardiovascular things for a start, so blood pressure, diabetes, lipids. Smoking and exercise are quite important. We need to look at liver issues, hepatitis B, hepatitis C, respiratory issues for people who are smokers. And remember, as they get older, they may be starting to get lung cancer, so we have to be alert for those. Bowel cancer, we at this point we don't have a screening program at the moment, but that's something to be alert for. Breast and cervical screening for female patients is important to make sure we get them into the system. We need to consider skin cancers, because some of these people will be spending a lot of time outside, so basal cell cancers, squamous cell cancers, and potentially melanoma, and dental care issues. So that thing of lifting the lip, one of the things I think we tend to do as primary care physicians is ignore the mouth, but these people will often have poor dental care. And then even look at ways of being able to provide dental care for those people. Some dentists will see people at lower charge. Some dentists will spend a half day a month offering free care to, say, homeless people. Some of these people will be homeless. There's a very good resource on this. This is from the Royal Australian College of GPs. It's called their Red Book, and that has a pretty good summary which applies pretty well to the New Zealand situation, except things like they have a bowel screening program and ours is just developing. So there are a few differences there.
Okay, Bruce, so we're looking at screening these people as we would someone of the same age and gender. Is there any particular age-related screening that we need to be considering?
Well, we have to remember that as these people get older, they have all the risks of the elderly. They have falls risk, hearing and vision. So there's all those sort of things that happen. We have to remember to keep up people's immunisations as they get older, their flu vaccine, tetanus, and those things. We need to know sexual orientation. If they're men who have sex with men, we need to check for HIV and about safe sex practices. And we have to remember with the women, they may get pregnant or want to get pregnant. If they're planning a pregnancy, then they need to talk about folic acid supplementation at time of conception, and then iodine replacement once pregnancy is diagnosed. So we have to remember that they have the normal problems of aging, of gender that other people have in the community. What
are some of the factors that are limiting the ability of primary caregivers to screen these people effectively? What aren't we doing so well?
Sometimes some of the physical health stuff is dealt with in secondary health care, and as I alluded to before, I don't think that's a good idea because the systems aren't in place for recall and the staff aren't set up. They're not thinking in terms of primary prevention. It's not their focus. There are other issues such as patients not turning up for their primary care appointments, and I think practices need to be proactive to chase people down. There can be difficulties in terms of communication. Fewer people have landlines these days. Service users may be more likely to have mobile phones, often with no money on them, phone number not working. So that's become particularly, the issue of communication has become quite difficult. And there's a separation of mental health from physical health, so it needs to be clear who's the prescriber, and initially that will be the mental health teams, but that may come over to the GP, and then who's doing the primary prevention. And sometimes these people actually have a health navigator that bring them from secondary care and introduce them to primary care, because service users get very comfortable with secondary care services and can be a bit scary and frightening going to primary care. So managing that transfer, the first visit to be done sensitively and welcoming for the service user, I think is actually quite important, because it can be a big step for some starting a new primary care contact.
So the communication between the primary and secondary caregivers is really important. How do we reduce the separation of care that we often see?
So I think one thing that can be quite helpful is meeting the people from secondary care, either going to their place and seeing who they are and where they are. Sometimes they come to primary care. In our clinic we have a psychiatrist who comes to visit, so we can sit and have a cup of tea and talk about patients. The letter communication I think is excellent these days. There's texting, phone calls and emails. They're all ways using the modern methods of communication to get quick answers about things. You can't have the psychiatrist in primary care all the time, but there are ways they are contactable. And I think both need to place importance on the primary prevention, or in some cases secondary prevention. It may, if some event happens like a heart attack, then it'll be secondary prevention, and just being clear about who's responsible for what. So if the prescribing's been done at secondary care, then primary care looks after the primary prevention. If the prescribing's been done in primary care, then both will be done in primary care. That's a little bit easier, of course. It's when there's the split that is the potential for the patient to fall through the cracks.
So Bruce, this is clearly a very important and complex issue. What are some take-home messages that we could start to implement in our practice from today?
Okay, so we need to be aware of the higher rates of physical health problems amongst this population, and constantly be thinking about how can we get to lower doses but with the same sort of clinical effectiveness. We need to have an awareness of the higher rates of physical health problems for service users, and also be constantly thinking about how we can have effective medication at the lowest dose, knowing that the side effects are dose related. We need to emphasise the importance of screening and primary prevention, and the fact that these people should be managed in the same way as people of the same age and gender, sexual orientation who are not service users. And finally, we need to reduce the separation between primary and secondary health care, and I think that's starting to happen. As I said, we have a psychiatrist come to our clinic, and the communication is very good these days. So,
thank you, Bruce, for your enlightening comments.
yeah, it's been a pleasure. Thank you.
Thank you.